Hi, tonight's webinar will begin momentarily. Thank you. Good evening, and welcome to our informative webinar series. Tonight's topic is palliative care and CF. My name is Matt McCluskey, and I am the founder and the executive director of the Take a Breather Foundation. For those new to Take a Breather, our mission is to give those living with cystic fibrosis the opportunity to take a breather from CF, and we allow them to rejuvenate in mind, body, and soul. When COVID hit last year, we decided to temporarily pivot this mission, and we decided to help those in the CF community that really needed our support financially. So we've been able to, with the help of our sponsors and donors, and all of you, we've been able to reach out to the CF community and offer financial assistance. And last year, that was in the amount of over $60,000 to things like rent, utilities was a big item that families could use help on, car payments, and we purchased computers for students who had to learn at home. And part of that, again, was due to our sponsors. So tonight, I'd like to take this opportunity to thank tonight's sponsors for supporting our mission and for supporting webinars and events like this. So a big thank you goes out to Vertex Pharmaceuticals, Viatris, Nestle Health Science, and Gilead Sciences. Thank you so much. And finally, before I introduce our speakers, I'd like to take a few minutes to do some housekeeping announcements for the webinar. Tonight's webinar is for information purposes only and general knowledge for the CF community. During the Q&A portion, you can ask questions by using the Q&A icon. It's on the bottom of your screen. Please submit your questions at any time, and we'll do our best to get as many questions as we can. For patient-specific questions, we do ask that you hold on to those for your personal CF care team. It's better if you ask them for their advice on those. This webinar is being recorded and will be available on our video, social media pages, and our website, which is www.takeabreatherfromcf.org. And we'll have that posted probably as early as tomorrow. Closed captioning is also available by utilizing the toggle switch also at the bottom on the lower section of the screen near the Q&A. Now I'd like to take this opportunity to introduce our two esteemed panelists this evening. Both are personal physicians of mine from the Hospital of the University of Pennsylvania, and I'm very thankful to have them this evening to educate us on palliative care and how it might fit in with our CF regimen of care. I remember talking to Dr. Hadjiliadis, and he told me that he was going to be out on sabbatical, and he was going to be taking a fellowship in palliative care, and he finished that, I believe, this spring. Correct me if I'm wrong. And at the same time, I believe Dr. Guerry came on board at this adult CF center at Penn as well. And so I thought, that would be a great topic, because I personally didn't know too much about the subject. I didn't know if it was the same as hospice, if it was different from hospice. So I thought, if I don't know it, maybe other people don't know it, and it would just be a good topic to touch on. And who better than our two panelists tonight? They can educate us. So without further ado, I will turn it over to Dr. Guerry and Dr. Hadjiliadis. Thank you.
Thank you.
Thanks, Matt.
Yep.
Roshni, I think you'll take over first.
Yeah. Can you see those screens are you able to see anything? I'm sorry. Can you see my screen right now or no? The PowerPoint? Here.
Not yet.
No.
Okay.
Just while we're waiting.
Here we go.
Oh, there we go.
Sorry about
Guerry is
that.
going to give
That's
first
all right.
an overview of palliative care, and then I'm going to talk about some more.
Yeah. So thank you,
Perfect.
Dr. Hodge. So I really do want to start with gratitude and just an appreciation for the invitation from you, Matt, and the Take a Breather Foundation. I was really struck when I heard about the foundation and all the great work you do, and it's just, I'm glad you're here. And thank you to the participants for coming, and I'm hoping this will be a combination of information, but also an opportunity to ask questions, so there can be learning all around. So I love my job. I feel I went into the best field of medicine called palliative care. I really get to focus on promoting wellness, which is why I went into healthcare. But I do admit that palliative care has a big branding problem, and it's often poorly understood. So what I'm hoping to do in my part is to kind of talk a little bit about what palliative care is, what it's not, how we approach taking care of patients in general, but also kind of looking at the cystic fibrosis population and why you should consider palliative care at times if it would be helpful. So, and then Dr. Hadjiliadis would speak further on really the evidence around palliative care and cystic fibrosis. So just starting with the definition, palliative care is actually taking care of patients with any diagnosis at any stage. A lot of it is focused on symptoms and the stress of a serious illness. And it is, as I said, the best job because it's about improving quality of life and it's about living better. And that support is for the patient, but also for the family, because we recognize that patients are part of a larger community. And when someone's going through a health concern, everyone is affected. Again, palliative care, and we'll get into how it's not hospice, but one of the big reasons why it's not hospice is it can be provided along with life-prolonging treatment. So it doesn't have to have, say, a limited prognosis. And it is very individualized. So whenever I get the opportunity to meet with the patient and family, a lot of time is spent on listening to their individual goals, what they're hoping for, what they're worried about. And a lot of the care delivery is aligned to the individual, and their values. I'll go into that a little bit more. So, kind of reflecting deeply with cystic fibrosis, and from my experience taking care of different patients and really appreciating what I've heard from other patients, there's often a lot of symptom management and treatment burden associated with cystic fibrosis. And I think, that those symptoms can be really varied, from, pain, bowel problems, joint problems, sleep difficulties, anxiety. And what's nice is palliative care is a holistic approach that's focused on symptoms and stress. So continuing to break down the definition I shared, the quality of life, as I said, is a huge component. And again, with cystic fibrosis, again, knowing it's lifelong and progressive, there's opportunities to really lean into what's important to individuals to try to let them live as best as possible. Again, complex decision-making is often a hallmark of cystic fibrosis, and things come up in terms of different opportunities, maybe transplant, what have you. And those decisions are very deeply personal. And it's nice to have an additional layer of support of a team member who's not necessarily your pulmonologist or your surgeon, who can kind of listen and really kind of reflect with some honesty about some of your goals and answer questions. It is often, I guess I said, I speak a lot about patients, but I also speak about families, and family doesn't necessarily mean by blood. It's really just the people that support the individual. And so we are trained to kind of listen and provide that extra support. And, the last point about unique goals, hopes, and values of each person, I think that's where we know medicine's not a one size fits all. And so palliative care does have opportunity and the time often to really understand what your goals are, so we can hopefully align a clear plan that matches that. So it's often when I say palliative care, I simultaneously will say supportive care, because that's what I see it as an extra support. And in terms of the team and what the palliative care team looks like, that can be really varied based on where you're located. So, some teams there's a provider, whether it be a physician, a nurse practitioner, and there's often palliative care teams that are both in the hospital as well as out of the hospital. And so that is nice because it can provide that continuity from inpatient to outpatient. And what's nice as well is palliative care by its essence, because it provides holistic care, is an interdisciplinary team. So ideally, the best complement of a palliative care team doesn't just have providers, but it has nurses, it has social work, it has chaplain support, really a holistic approach. Just because of where things are, not all outpatient programs necessarily have that robust of a complement of a team, but I think it's nice to know that those layers are thought of as part of the framework of palliative care. So just to kind of go into the big elephant in the room about, well, when I look up palliative, like hospice pops up and, is this about dying? And, when we think about palliative care, it's really the continuum, as I said. What we do know is the best outcomes for patients, the patient outcomes that people value, so being pain-free or at least manageable pain, treating anxiety, having good understanding of your illness and communication. When you use palliative care at the beginning of a diagnosis or as a progression of disease, there might be a lot of life prolonging care at that time, and maybe not a lot of symptom burden. But as that shifts and maybe as treatment options decrease, there is often more symptoms, and that's when palliative care can be really helpful. So this graphic is just really showing that there's often an ebb and flow of what kind of supports you might need depending on where your health is. And I think transplant has a different trajectory where, again, if someone's, say, in the path for transplant, and you get to a certain place of illness before the transplant is being offered, palliative care support might be needed a lot in the beginning, right before pre-transplant. And then if things can, as we hope, go well, you might not need a lot of palliative care until later. The hospice part is really when there's no more life prolonging treatment and the goals are really focused on comfort, and potentially the prognosis would be that we wouldn't be surprised if someone passed within 6 months. So that's really what hospice, and hospice does provide that bereavement support. Hospice is similar to palliative care because they're great folks that are focused on quality of life and improving symptom management as well. So we use a lot of the same tricks in terms of treatments and things like that, but the big difference is palliative care can happen at any time and any stage of the diagnosis. So symptoms, I mentioned that, and I think, again, it could be anything. This is one of the best parts of my job, is I can really ask what bothers a patient most, and it could be, from runny nose to itching to shortness of breath to sleep trouble. I try to explore and see what we can do for it, and really generally a more holistic approach too. It's not always about adding medicines. Sometimes it's about adding non-pharmacologic, different holistic approaches to help with those symptoms, and working with your teams to make sure we're all aligned. And as I was mentioning, the help is definitely not just on a physical level, but really the communication support. Sometimes I feel like in palliative care, we're translators because, we do a lot of talking to patients and families about their goals. And, often the cystic fibrosis population I've had the chance to work with is a very sophisticated population, but sometimes still that translation is helpful for, really getting to the root of what's going on. I think, as I alluded to with the different interdisciplinary team members, it's not just physical stress, it's also spiritual and social distress. We're not to replace social workers and other people that help with these things. It's really just an extra complement. And then another big piece that, I think there might be a role, and, I will ask Dr. Hadjiliadis to speak on this, that maybe all patients with cystic fibrosis might benefit from in terms of connection with palliative care is advanced care planning. So what that really means is around having an advance directive. I have an advance directive. I fortunately don't have an illness right now, but I do have a family. And so really making sure people know what my wishes are in an advance directive, a living will, that kind of thing is important. And we do know that most people want their doctors to talk about it, but often it just is not happening. And not many times is it translated into the medical records. So sometimes these advanced directives or living wills are completed, but it's in a lawyer's office or someplace. And really the best form of advanced care planning is one that's based in values and goals. A piece of paper is a piece of paper, and unfortunately, when that paper comes into play, you're not in a place to have a voice to speak to it. So that's when you really do want the conversation to happen. And so when we orchestrate advanced directives and advanced care planning, it really is a deep conversation, and ideally with some of the loved ones that might speak for you present. And again, it is based on your values and goals, because that's often the best way to approach it. So I'm probably going to pause there. I guess, I think I'm hoping that this sparks some questions and we can kind of talk further, but I'll stop sharing screen and I will turn it over to the one who knows so much more than me.
You taught me a lot already on the palliative care side. So let me just share my screen. And can you see it right now?
Yes.
Okay. So on my side, I'm going to have a little more technical information about some data from cystic fibrosis, just to show, where the patients feel that they are based on different surveys and different studies. So this is a study from Elaine Chen, who is actually a pulmonologist and a palliative care physician from the University of Chicago. And they went in their center in the adult patients and queried them. And they found out that the vast majority of patients, many of them with mild disease, had significant symptoms. Pain was present in a significant number of people. A lot of them had shortness of breath, and it depended, on what they were doing. And you can see in the graphs that, they were more common in people that they had basically, worse lung function. They tend to have more symptoms, but it happened even without, you might feel, short of breath, or you might have pain, even if, the numbers look okay. And also the importance of advanced care planning. It seemed like people that were more sick, they were more likely to be thinking about this, which also makes sense. When we're all, younger and healthy, we think we're invincible, and then it comes a little more to mind as we get, older. And the advanced care planning, at the minimum, type of things, it might not be exactly what, you want or what but it's at least to have somebody who's your surrogate, who's the person that speaks for you if you're not able to speak. And that's a significant thing. And it's significant to know, especially if it's somebody that's different than what would legally be the person in the case. So in this study, Elaine showed, that basically symptoms exist in a CF clinic across the board of spectrum of disease. Let me go to my next slide. This one is another study from the University of Ottawa. BC means breathlessness catastrophizing, but basically it's in a way where people, feel short of breath, but they also think of the worst. It's in a way, of saying that I feel I'm gonna, feel short of die. I feel bad about the future and all those things. And what I found out in a sample of about 50 patients, people that have, the symptom, they had more depression, more anxiety, more pain. It was more common in women. And when they looked at it, they found out that these patients had, worse quality of life. And they were, all of those things were worse. They were predicting a bad quality of life better than FEV1. So in some perspectives, how you felt, it was more important on whether you had some other, symptoms of anxiety than your lung function. And the majority of your quality of life was basically explained by how much, breathlessness, catastrophizing you had, basically how short of breath you were in many perspectives. And, based on those, the Cystic Fibrosis Foundation, with some of the palliative care and CF, leaders, Dr. Dellon from UNC is one of the pioneers and trailblazers in this. They led a study of adults with cystic fibrosis, caregivers, and care team members. And they asked them, is there a need there? And there was a high number of people that they said there is a need there. And there was a lot of concordance, a little bit of discordance. But all, three groups, they said that emotional support would be good. Management of anxiety was very important in caregivers and patients. Advanced care planning was also important in two of the groups, and decision-making support. And the barriers, well, one was that there's lack of access. We didn't have, we're not lucky like at Penn to have Dr. Guerry, where we can, and Rachel Kleindus, where we can have, palliative care in our, backyard. We didn't actually, until recently, we didn't need it. The fact that the CF care team might not be as versed in palliative care. And the final thing, which Dr. Guerry tried so hard, to show, palliative care is not because, you're dying. There's other, things that it can offer, which are beyond, that. So those were the barriers why people, didn't think about it. Finally, when they looked at people that unfortunately, passed away, but they found out that, a significant number of people thought about advanced care planning, but it didn't happen until the very end in many cases. And many cases of patients, that died, there was poor control, according, to the families, of a lot of significant, symptoms. And here is, the palliative care specialist led to less mechanical ventilation or death in the ICU. I'm sorry, that's just a typo. And I'm going to go into some other initiatives that the Cystic Fibrosis Foundation has started. So in the recently published Advanced CF Lung Disease Guidelines, they suggested that individuals with CF that have severe disease, they have those conversations with their providers, and they make sure that they discuss things about what happens if things were to get worse, who helps them with decisions, and also about lung transplantation. And of course, all those things are difficult because, as we know, cystic fibrosis has very variable disease progression. Sometimes people can stay stable for a very long time. And now with the new medications, oh my God, this is a different disease. We have, so many more people that are doing better. That's amazing. But still, it's a serious disease. So this is, one of the issues that they wanted, to make sure that it doesn't happen very late. Make sure that we serve the patients where they need to be, whatever, their wishes are. And other parts of the guidelines, they also, talk about treatment of pain appropriately. So you can see that they made, a statement that, opioids, if they are needed for shortness of breath or for pain, they should be, prescribed. But also they said that at the same time, there should be, appropriate consultation with pain or palliative care specialists to help out. So they'll make sure we have an extra, layer of support there, because we all know that those medications can be, dangerous and can have many times, bad side effects. And at the same time, a couple of final things was, to make sure that we think about mental health on everybody, treat, depression, anxiety, and any kind of, symptoms that are, significant. And also there is a recommendation about having, some kind of a family conference when patients have more severe disease, so that all those things are laid out with a lot of support from different, members of the team and different family or loved one members. I'm not going to dwell on this, slide. It's a little busy, but this is basically another, effort from the CF Foundation and Dr. Cavallaratos, who was together with Dr. Dellon, and they basically found out, they just put a roadmap on, how, like the CF team should start certain things, how you should get a consultation, and how you should screen, patients to make sure that you meet their goals. So this is first part of, set of guidelines. There is actually right now groups that are forming to try and treat, pain in cystic fibrosis and try and treat, shortness of breath symptomatically. So this is, an effort to try and meet the patients where they are. And to show whether this works, this is a very small pilot study from Boston. It used the CF Cares model, which used a lot of what we call integrated interventions. So things like acupuncture, cognitive behavioral therapy, stress management. So they added those to patients that had high screens for certain things. It's a difficult slide, to see, but effectively here you have different, basically scales for the stress used in palliative care. And for some of them, they had the issues that were related to psychological and, respiratory issues. And they divided patients with advanced disease and patients without advanced disease, especially for the advanced disease, which is, the group that has, the lines that are intermediate. And but for the other groups, you can see that the intervention tended to make things better. Lower is better on this graph. They also looked at their PHQ-9 and GAT-7, scores. Theirs, high is bad. So after the intervention, things, went, a little bit down. On the other hand, the CFQR, which is a quality of life questionnaire, in a very small sample, tended to go a little bit up. So this is a pilot, intervention. There's more things. There's actually a couple of trials that are happening right now, funded by CFF, to try and find this out. But those are areas where simple things, what we consider, maybe sometimes the soft parts of medicine, and I'm putting that in quotation marks, might have a positive effect on the well-being of patients. So, this is like my evidence of saying that there are times that palliative care can help to have in the multidisciplinary care of teams. Like we have, a dietitian, we have a psychologist, we have different things. Palliative care interventions might help, the patient feel better and potentially, even, live a better life and live longer. And also, they live the life the way that they would like to to the best of their abilities. And I'm going to stop here and stop sharing. And I think the next part is going to leave it open for questions from people and comments. And, we're open, to that. And I think Matt and everybody else will have, some control of the chat.
Okay, great. Thank you. That was great. Thank you very much. Dr. Guerry, I think you summed it up with one word for me anyway, when you said supportive care. Palliative care is another term for it, would be supportive care. Again, like I said, when I first heard the term, I was thinking, hospice, but it really is helping us as CF patients with different needs. And for some patients, obviously, there are more needs than others. And I know with talking to you, we've had some really good chats regarding like some of the pain management topics. I would say, I wake up and I'm sore, but as soon as I go out and walk, everything starts to loosen up, and, it takes away some of that pain. And even if I do have to use an opioid, it just takes the edge off a little bit. So I'm able to walk that extra distance, because as a transplant recipient, I want to make sure that I'm in the healthiest shape that I can be in. So it allows me to go that extra mile, push through it a little further. So it's things like that I think that palliative care brings to the table, and will definitely benefit the CF community. So it's exciting to have this new approach at our center. So we'll start with some of the questions here. If someone is interested in adding palliative care to their CF care plan, what do you think the best first step would be?
You want me to take this one?
Yeah, go ahead.
So that's a tough one because of location. So that's the one thing, that's more complicated. So I'm going to tell you about our clinic, but our clinic might not be the same in different places. So in our clinic, all you need to do is discuss it with one of your physicians or nurses or team members, and we place a consult. And the consult, basically goes, and the next visit, you can do it at the same time or at a different time. You see the palliative care specialist, who will ask us on the referral, what would you like, done for this? But also, they will ask you, what are your goals about this? What, can we help you?
Yeah.
In cases where there's no palliative care integrated within, the clinic, it makes it a little more complicated, because unfortunately, this is not yet, as much available as we would like it to be for everybody. So, but if there's not, it depends on where you are in some perspectives, but that's where, things are. And the best thing to do is speak to your team from my perspective.
And just to piggyback on that, you're right. I think access to palliative care, especially in the outpatient setting, is really not where we need it to be yet. So just like you said, using your team to see if there's a reference. There is a website called getpalliativecare.org, where again, it can kind of highlight, if once you put in your zip code, where there might be some palliative care teams around. A lot of times outpatient palliative care has been limited to cancer patients. So you might find that these programs are not yet open to a wider population, which I think is a shame, but hopefully will improve in the future. And then you might see that some hospice programs have a palliative care arm. That being said, I think for the cystic fibrosis, population, just going to your care team is the best way to go.
And most hospitals will have it on the inpatient side.
Yes.
If you end up,
that's pretty standard.
Depending on some features, that probably will be there for sure. I hope that answers the question.
Yep. Okay, great. Next question. Can you please say again the different members of the palliative care team? Palliative care specialist, sorry, I'm killing the word, a palliative care specialist. And then I think you said there are people with other specialties. can you please say again what those specialties are? Thank you.
Yeah, so again, just like we mentioned, there's a lot of variety of what palliative care looks like in different locations. So the full complement of what palliative care is could be variable. So when I say provider, I'm talking about someone who has prescription ability. So whether it be a nurse practitioner or a PA or a physician. And then often there could be a social worker who's more for behavioral support and counseling and supporting to illness rather than so much of the navigation of insurance and those aspects of social work case management. The third member that's often connected to a palliative care team is a spiritual counselor or a pastoral team member. And then there could be, again, nurses that help with addressing symptoms and helping kind of interface with some primary education. It's a little bit of a hodgepodge. I think it's you'll see not all programs are in the different stages of maturation. So some programs are a lot more robust than others and have the full complement. At University of Pennsylvania, our outpatient team right now, we have providers, but I have access and able to kind of phone a friend with some of our inpatient team members that have all those other complements of providers. So.
A pharmacist is also, sometimes a part of, the
Yep.
team.
Pharmacists. Sometimes there's specifically psychologists. Sometimes, it's, and I've definitely have had teams where they've had more integrated medicine clinicians. So whether it be someone who does Reiki or massage or things like that. And often a palliative care team might even have someone that's focused on bereavement. So even though they're not hospice, we recognize we take care of patients at any stage. And so there is often someone who's trained in grief and support for that.
At Penn being, relatively new, we don't have, yet on the outpatient the full complement of this, but many times, as Roshni said, we lean on our colleagues on the inpatient side. And also we would lean for some of the support, for CF team members that might not provide the same type of support, but certain features they might be able to help us out.
Mm-hmm. Mm-hmm.
Okay, great. Okay, the next question, where in the life cycle or CF exam visits do you think palliative care is best introduced?
It's a good one. I don't know. Do you want to start, Dennis?
Sure. So based on what Dr. Guerry showed you, potentially could be any time, but realistically, let's say, right now you started on Alexa catheter, Tesa catheter, Iva catheter, you have a lung function of 110%, you don't do anything and you feel fine. That's and you're a 20-year-old. That's probably not in your mind, to think about, what do I need for this? Okay. Even though, the one thing that's always important, even if you don't have, other symptoms, is make sure that you have not necessarily a full advance directive, but at least know who is speaking for you. You never know. You might go biking or you might have, an accident. You never know who is going to do that. So that's an important aspect, no matter what, okay, from our perspective. But I would say, if there are, symptoms that are bothersome, they are more common than not at different times on the other. No matter what those symptoms are, that might be a good time to introduce palliative care. It might be a good time to introduce palliative care if there is, areas of disease activity that make significant decisions that need to be made. Transplant is an example, but it could be, having a major surgery, even having a G-tube or something like that. If you think about it, something that, it's a big decision that kind of changes the way that you're thinking this. Maybe that's another sounding board. If it's not, something that's it's gonna help you, make the decision with somebody that's an arbiter outside of, the things, and talk things over and make sure that whatever, you decide is appropriate for your values. And I liked what you said about values. Many times I use the word philosophy. We don't want, we can't have every specific, area and situation that's going to happen. But it's more important to know what the philosophy of how you approach, things are. And it's important for your family to know, your loved ones, I should say, not always, your blood family, the people that are around you. I don't know.
And I think there's, sometimes what happens is even if I meet someone who's really in a very great place with their health, we we can develop a relationship. I can encourage completion of an advance directive, and then I could say, hey, you got my number, call me later if you need me, so it doesn't have to be as an intensive relationship as someone maybe I'm working with acute symptoms, or who's facing a major decision point and they need more kind of counseling. One thing about palliative, the best way to do it is by developing a relationship. I'm sure you guys know that your relationship with your pulmonary team is so essential, and your CF team. Same thing with the palliative care person. I can do more and better by a person once I have a better sense of who they are. But you're right. It's not necessarily every single person needed at the beginning.
Okay, great. Thank you. Next question. What are some initiatives that are being taken to extend the reach of palliative care programs, like getting them at more hospitals throughout the country?
I'll start and then you can chime in. So it's a great question, and I feel like I want whoever asked that to keep asking it in all places, because I think the reality is it needs to be prioritized. So there has been different legislation even, and focuses on the value of palliative care, and it's happening at all levels. So there is more of attention on the need to train palliative care in med schools and residents and fellows. There's a higher devotion to treating and training patients, not just physician levels, but all APPs and nurses, to have some basic primary palliative care skills and then higher palliative care skills. I think what's been nice is that with studies and some of the ones that Denis showed and other people have showed, is we've showed the value on the personal quality of life side of things, but there's also been signs that palliative care can help with the value of healthcare utilization and making sure people, when they're at the end of life, are getting the care that they want. So the argument is there. It's now just really getting the kind of the funding and getting people to really buy on and commit to this. I sometimes say palliative care is like the slow food movement of medicine. So we're not fancy. We don't do a ton of procedures and those kinds of things. But again, the quality and the value is there. So I'm hoping with continued policy work, I'm hoping with continued ways to reach a higher population of providers that have experience with palliative care, know how to talk about it, know how to get people the resources will help. And then I'm hoping institutions will really kind of, like the CF guidelines say, that palliative care is part of usual care and we have to have it.
And that's the only thing I'm going to add, is that the foundation, by doing this, they're trying to normalize this, make sure that they make a statement that this is important in the care, so that more health systems and more insurances are going to cover more of those things. And then the second part behind it is basically also teach the primary CF teams at least the basics, so that sometimes even if we do not know how to do the very advanced stuff, you can do the early things. A little bit like the anxiety and the depression guidelines, they had an effect in us being a little more proficient and being able to have something to lean on, because we all know that we had trouble accessing mental health care, but being a little bit better in doing it, at least, the early parts. Maybe we can't help everybody, but we can do a little bit of something instead of saying it's not our job. Our job, as CF providers, to be there for the patients and for as much things as we can. We can't do everything, but we can do as many as we can, basically, whatever the needs are.
Okay. Next question. Are palliative care treatments such as Reiki and acupuncture covered under insurance if ordered under palliative care order?
Unfortunately, the insurance coverage and payment models for these complementary alternative medicines is really not there. I encourage people to use their flex spending or different things if they can, but I don't know if you've experienced opportunities where we can get people connected. Denis, I know.
No, not yet. But if you see, the studies that are being done, for example, if they show positive results, those are, the first, signs that, might push towards insurance, approval for things like that. So we're not there yet. We wish we were, especially for treatments that, might have very little harm. And I'm editorializing here, but a lot of the times, for example, for symptoms like, pain, why do people refer, to using a lot of opioids? Some of it is because, this was covered by insurance and it was easy to do, while a different therapy was almost impossible to access. But that's a different story.
Yeah.
But we're plugging
a
a
different webinar.
Yeah.
Okay. Next question. Thoughts on sitting down with patient and loved ones to discuss palliative care and advanced directives? Would it possibly be helpful normalizing to have the patient's group nucleus have a shared values discussion, since it applies to all of us per se? Get elephant out of the room and learn each other's needs.
Definitely. And I don't know, when you're referring to group nucleus, are you talking about kind of your family and the people that surround you? But if that is the case, you're right. I think the reality is this needs to be normalized. And there's been some really, I think, moving pieces of work. So Atul Gawande's book, Being Mortal, which was a New York Times bestseller for many years. I think there's more conversations and more, and not even in the healthcare realm, but in the public realm, that we need to have conversations about our goals and values and what dying looks like. And so there's a really great website called The Conversation Project, and they have a free toolkit where it actually does a very nice guided conversation between like two family members or two friends to talk about their values and goals. And that can be a really rich opportunity to then translate into a formal advanced directive. But I've had patients that have taken the opportunity to say at Thanksgiving or different times when families are together to really kind of have a conversation about goals, and as you said, take the elephant out of the room and normalize things.
And I think from a CF perspective, for many of us that have participated in some of our quality improvement initiative for transplant for the last 3 years, this was the same effort about transplant. Let's speak about it early to normalize it. Nobody's excited, to hear those words, but the idea was you do something early to normalize it. It's part of, your care rather than anything else. And I fully agree with that. I think, you can't force some people, might not want to, and that's okay. But I think sometimes, just normalizing is the right thing to do, and it helps you.
Yeah, to add a piece of personal background before my transplant, that's what we did. We met as a family unit. I remember in my parents' living room, all of us, brothers, sisters, parents, my wife, and we just discussed before I had the transplant, what my feelings were post-transplant, during the hospital stay. So everybody kind of put it all out on the table, and we all knew going in what everybody's expectations were, and it made it so much easier getting through it. I was lucky that I had such great support from my family unit. So that's exactly what we did. We all met as a family unit and discussed it, and I think it was definitely beneficial. Next question. Does palliative care provide Reiki on its own, or are you only able to set up PAL patients with connections?
Yeah, it's more, there might be some palliative care folks who have certain certifications, so that might be the case, but generally it's connecting or making the recommendation to then ask people that in the area that it will be good practitioners. So it's possible that there's where I was in Rochester, New York, we did have a massage therapist as part of our team who was also a Reiki specialist. So she was able to provide that support for patients when we were in hospital. But again, it's not necessarily all universal.
Okay. Next question. I'm aware that if there is no steady decline of a patient on hospice care, they can be removed. If a CF patient's lung function increases since being placed on palliative, will the patient be discharged?
You're not placed on palliative. This is something that you choose to, if you have, issues that you feel like they're beneficial, you probably continue to see your palliative provider. If those issues, are gone and you're feeling great, maybe it's like what, Dr. Guerry said, just you have my number, call me if there's any issues.
Yeah.
So
it's less like hospice is really a bundle of care.
Yeah.
So it's really kind of like a program, hospice, because it comes not only with that philosophy that we mentioned, but it comes with home care or medicine support or equipment and things like that. Palliative care is not a program. It's more of, you could think of it as just like a cardiologist or a dermatologist. It's another specialty that is a consultant that's a resource to you. So you don't necessarily go on palliative care or go off, but it is a service that maybe you don't need as intensive support or intensive follow-up from this consultant than others.
Like when you have a blood exacerbation, you see your CF provider maybe every week or every other week. But then if things are going well, we go down to every 3 months, and sometimes people, even less frequently.
Okay. Next question. How did each of you get started in palliative care, your journey in getting started with Pal Care? Was there one thing or repeated prompts that led you to the study?
That's great. The aha moment. I'll go first, and then I'm really excited to hear yours. So interestingly, I think it was my liberal arts education. I had no clue what kind of doctor I wanted to be. I loved everything as I kept going through. And so I did internal medicine and pediatrics, just because, again, I like taking care of families and diagnoses of all stages and the whole population. And then as I was doing it, I fortunately trained in a place where they had a lot of palliative care attendings. They each had different other scopes. So some of them were primary care doctors, some of them were oncologists, some of them were neurologists, but they all had this similar theme where the focus was on deep listening, alleviating suffering, improving quality of life. And I, really gravitated to them as well as the nurse practitioners they work with. And I fortunately had a mandatory rotation as part of my training in my med-peds residency. So then that was it. Once I participated in that rotation, I was like, this is what I want to do. So I was fortunate about that I had that exposure. And that's one thing that we spend a lot of time in our palliative care team is the devotion to education, because it would be really great for people to have that exposure in their training in healthcare, that palliative care is out there. And so, again, it might lead to people choosing it as a career, and we hopefully will have more access, or it might just lead to opportunities where they can provide that primary skills and complement of the other fields that they help with.
Great.
And on my side, I have to say that I've enjoyed, being a doctor takes care of persons with CF and being a lung transplant, doctor. But in many perspectives, what frustrated me the most is that at times there were symptoms that we were not doing as well in treating. We were not serving, the needs of patients to the way that I felt that we could. And I was impressed about how many people, sometimes, the numbers might say one thing, but they felt, not so good, and vice versa. Other people that their numbers were bad, but they were feeling okay. And it impressed me how many times mental health issues and other little things that we ignored, we didn't, take into account. The other thing that I was frustrated with is sometimes not having those discussions, having either people, refer too late to have a transplant, and then, it was too difficult to do it, or too traumatic because it was done in a very late, fashion, and vice versa. People sometimes getting, treatments that they really didn't need or didn't want. And unless they were very able to voice it, they got it because, that's just our default. So, in the middle of my career, I felt that this might be something, an addition that might help me provide better care for the patients beyond what I know.
Okay, and I think we just have one final question here, and this is probably directed more specifically to you two at Penn. Are there telehealth appointments available to patients who live a distance from Penn CF Center?
Yeah, so I think the pandemic has showed us a push to be virtual, and fortunately, palliative care became nimble and did that as well. And I've really enjoyed the opportunity to do telemedicine, and you can do it in a very compassionate and empathic way. I think right now, Penn, like many centers, are still trying to figure out the landscape of telemedicine billing and rules. So there's currently, I definitely can do telemedicine for people that are located in Pennsylvania. Out of state telemedicine is becoming a little bit more of a challenge, but I know the institution's working on it. Yeah, so I think we get emails pretty regularly, so we're working on it. And a lot of us are working on getting licensures in multiple states, so it'll help us.
We're getting conflicting emails for out of state. Last week we were checking our emails and we had two opposing emails for different things. But in Pennsylvania, the answer is yes. The other difficulty, and this is a little more complicated one, is at this point the palliative care team at Penn is connected to the pulmonary team at all the Penn hospitals. So usually to see the palliative care specialist, you have a connection to one of the pulmonary people across the board. Could be as far as Princeton, it could be Chester County, it could be Lancaster General, but that's how it works right now. I'm not saying that this is the best, but that's another limitation that we can talk about. If somebody has specific needs, what I would say, contact us.
Yeah. My specific program is linked to Penn, and it's hopefully we can continue to improve that and increase access.
Okay, well, that concludes tonight's webinar. Thank you so much, Dr. Guerry and Dr. Hadjiliadis. As always, this conversation with you has been very informative, and we appreciate your time and your insight on this topic. So we are very thankful for giving your time to us tonight. Also, a special thank you again to our sponsors, Vertex, Viatris, Gilead Science, and Nestle Health Science. Thank you for helping make tonight possible. And thank you everyone who tuned in this evening. We hope you found this informative. We hope to have other webinars as we see fit. This is recorded, and we will have this placed on our social media and our website probably as early as tomorrow. So, and I think every attendee gets an email with the recording as well. So thank you very much to everyone for being here again, and have a good night. Stay safe and be well. Take care.